Okay, got a fairly slick presentation, hopefully, because time is limited. You'll be pleased to know lots of pictures, not too many words, only a few numbers. But firstly, we wanted to make it slightly interactive as well. I think Paul rightly said we've got quite a long morning with lots of interesting conversations. So we've got a couple of questions for you, but to practice in readiness for those, first we would like you all, those who are able to and willing to, would you stand, please? And sit. No, I got nowhere to sit. And stand again, please. And please sit down again. Okay, you'll get the point of that as we go along now. It was more than just checking how compliant you all are. Okay, next slide. Okay, we had a very fortunate opportunity only a few weeks ago to go and spend some time with Roberto and his incredible team of staff out in Trieste. I think we were all ambitious before we went, that there was a lot to learn, but I think it's fair to say that Liz, our other health colleagues, our local authority colleagues and the police colleagues who came with us were just blown away by what we experienced out there. Paul has already said today is about inspiring and learning. That week was probably one of the most inspiring learning events most of us have had in many, many years. It's challenged long-standing beliefs that we've held, long-standing practices that we've encouraged as both clinicians and managers, and it's given us much food for thought, and that's what we want the focus of this presentation to be about today, is creating more food for thought. That's not to say that local people and local services do not do a good job. We're very clear about that. They very often do. They very often do that under very challenging circumstances. But Phil rightly said yesterday in his speech towards the end of yesterday, there's an opportunity now. Prudent healthcare is very strong on the agenda. Co-production is being encouraged at every level. But the challenge that we've got is that we can't continue to do the same by doing less of that. We need to do something different, and I think that's what Trieste and the visit has given us as a team of people, is to think about how we can go about that very differently and get probably better outcomes than some of what we're doing at the moment. I'm going to not go through this slide, but those are the main areas I'm going to cover. Then I'm going to hand over to Liz to do some of the other work then. Pretty self-explanatory. Population, we're bigger in West Wales. Our geography is pretty vast as well. Spend, when you start to aggregate that across per head, is fairly similar. They're rough figures at this point because we need to make sure that we're baselining against the right things, but it's a fairly similar comparative. What is interesting is where the money is spent. Trieste's ambition is to spend 50% of their money on community services as opposed to hospital and traditional services around that way, and they're very well on that journey. We've got a long way to go, I think, at this point in time. Started from very big hospitals in very similar places, and you'll see the bed numbers aren't that different. When you start to look at those beds, though, you start to see where the difference lies in some of the model. So supported places in the community. Okay, we've got some, but not as many as Trieste. Community and crisis beds, we've got one in Hywel there. The whole focus of the model out in Trieste is around community and crisis beds that they actually call hospitality beds. They were very different to ward-based beds that we have in traditional ways. What you can see is that we've got a lot more ward traditional type beds, acute general hospitals or psychiatric wards in that way. They've got 6 beds in Trieste, and I'll talk a little bit more about that. They've got no psychiatric intensive care beds. We just kept scratching our head, asking stupid questions to the point where we looked like a bunch of numpties at times, because it was so different to try and get our head round. No locked rehabilitation beds. So the total beds are not dissimilar, but actually the occupancy rates are very, very different as well. When we've started to come back and compare ours, over 100% is probably being kind to us at times. Okay. Yeah. One of the fundamental things that we struggled to get our head round and understand, really, as a mental health nurse by background, worked on wards, managed wards over many years, was doors. And the way they manage their service. So this is our first question to you now. Please stand if you think it's possible to have open doors in all areas where we've got psychiatric and mental health beds. So if you think it's possible and doable across the whole system, please stand. Brilliant, we've got the converted. Okay. Out in Trieste, they don't lock doors. They just laughed at us when we kept asking questions about locked doors. Their wards are open, their beds are open, they don't even call them wards. People can come and are free to leave and come as they go. And we had to ask ourselves the question, what message does locked doors give? You know, do we create some of the things we do? But actually, one of the people, I think it was Daniela, one of the team out there, actually said, don't think about it just as doors. You know, if you just open your doors, you've got serious problems. What does that signify? What does it mean? It means a whole change in the way we work and a whole change in the way we think. And it was stressed to us that just unlocking the doors is not a solution. It's possible only with whole system approach, and Liz will go on to describe some of that. Restraint, question 2. If you think it's possible to never use physical restraint in inpatient areas, please stand. Okay, not bad. Okay. One of the strangest things for me to get my head round out there as a nurse who's worked in psychiatric intensive care units is they don't train any staff in restraint. They don't use restraint in the way that we would do in this country. We're having huge debates about prone and supine restraint, but actually they don't even bother because it's not an issue for them at this point in time. And the next slide, although painful to see, is not quite what practice is like these days, but it's not far off. And that's what it's left us challenging and thinking about. It was painful. Our staff wear uniforms in some of our inpatient areas. They're trained in restraint. It is meant to be a last resort, but it's still very prevalent when you look at our statistics and our data. We mean well, and we often frequently do very well with people in our service, but once again we have to ask, you know, how could we learn to do this different, and how can we reduce or eliminate such interventions if the relationship is to be at the forefront? As part of restraint and understanding their model, one of the things that stood out for us was their environment. It was like walking, without advertising anyway, it was like walking around IKEA, was the best way to describe it. Lots of light, easy, practical furniture. We buy chairs that people can't pick up and throw. We put our TVs behind screens. We use plastic cups or shatterproof cups and things. The whole environment is geared up to say, we keep you safe, you don't need to take responsibility for yourself. And there's a fundamental shift in that I think we need to work on. We had the opportunity to visit many services, meet with many users of the services out there and people across the whole system of care, and each of us came away with lots of things to think about and lots of profound conversations that we had with people. But we went to a project where some young men have been working as part of a social cooperative to make a flat habitable. It was beautiful. They'd set up a process where they were party to who was going to live there for a period of time to help them learn some skills for living. And there was a young man there who was profoundly unwell. He talked to us about that experience. We were pretty confident he'd probably be in a more restrictive environment if he were in Wales receiving his treatment at that point in time. But what he said to us was about crisis, is if there are too many operators, which they refer to as staff, when I'm in crisis I feel threatened. And again, food for thought for us. Whenever we feel a ward, a clinical environment is busy, is tense, what we typically do is throw more staff at it, and we have to question whether we create more aggression, more violence, more tension in the system by doing that. Don't typically show pictures of bathrooms. It's not the prettiest bathroom, but this is actually a mental health unit in Wales that only opened 4 years ago. Very clinical looking, black toilet seat in itself. I wasn't sure they even made them anymore, so it's probably come from the stores that's been hovering around. But it's not bad. We'd accept that as pretty good, actually, in this environment. But what stands out in that is that it's designed to be safe. There's no ligature points in there. You won't see taps on sinks. You don't see rails. This is a picture of a bathroom in Trieste, not the best picture. Our cameras weren't working particularly well in that dark environment, but it looked like a really nice hotel room bathroom. But what you'll notice are rails. everywhere. There's ligature points, there's rails, there's no concern about any of those things. And that for us, again, was fundamental because there's been a big push on ligature points in Wales, and we have to ask, are we putting our focus in the wrong place? If we're trying to manage the environment, are we forgetting the person and their interaction with that? Legislation, interesting for us and something that becomes a challenge that we need to think about because it's very different and those are often some of the drivers, but there's a very light touch with legislation in Trieste. You can count on one hand the number of people who have involuntary treatment at any given time. Very, very small numbers, whereas we know that's still quite a high proportion for us in Wales. So they don't use it very often, but actually what happens is it comes from a different base as well. So we've heard a lot over yesterday about relationships and the fundamental importance of that. Well, a lot of our clinical staff are very heavily involved in restricting people's liberty, moving towards involuntary treatment, and the way they use the law is different, so it's much more managed in the judicial system, so we do need to think about that. Okay, the results. Yeah, this one's mine. Go on, can I do the first bit? We've just done one table about results, and this is where Liz and I will flip over at this point. What we've got is a little bit of data to show you some of the stark reality of this. You've seen environments with ligature points everywhere, open doors, no staff trained in restraint. Yet when you do a comparison of suicide rates in Trieste and in West Wales, there have been none in the last 5 years in Trieste. There have been 7 in our inpatient services within West Wales, which is a pretty shocking number, really. We tried to do a bit of comparison around the involuntary treatment. We're not quite sure our data is very accurate yet, but it's not far off. So typical length of involuntary treatment, bearing in mind it's very infrequently used anyway in Trieste, is 10 days. Ours is 44 days. Bed occupancy we've already done, but one of the startling figures for us is that they were very proud in Trieste, and rightly so, was that they've had no admissions to secure services in the last 5 years. When we looked at ours, we've had 90. So a phenomenal difference. So we have to ask ourselves, what their culture and their approach to this is doing in terms of outcomes, and what of that is transferable.
Okay. Good morning. The visit to Trieste for me was moving, humbling, and certainly challenged my fundamental beliefs about the way we deliver our services. My primary area of responsibility is adult acute care, so it's inpatient services and crisis services, so you can imagine how these figures have kind of left me wondering about how we can be doing things very differently. So how and why? The attitudes to mental health is that of acceptance. The availability of a mental health service is 24/7. There's no formal referral mechanism, so if you require input and help, that is what you will receive. An absence of waiting lists and an ownership of the community being responsible for the person or the people who live in your area. Supplementing and adding to the individual support structure and is central to how the service is delivered. There's no referral detailing your eligibility. The language is so different. You are accepted. How much more engaging an approach this is. The service offered to you is age and condition blind. If there is something that can be done to support you, then it will happen. A whole sector consistency of vision. Wherever we went, the role, the purpose of the service was shared by everybody. All community treatment centres, right through to the family and carer support centres. The vision was clear and shared amongst everybody. At the can you hear me? At the family centre, there was a doctor who acted as an interpreter for the carers there and really helped us to have a really meaningful discussion and engagement with that group of individuals. Oops. Right, the relationships. A person, not a patient. How this so ties into some of the approaches that were presented yesterday from the lady from Finland and the CAMS presentation that we had. An understanding of the person, forget the patient, don't even go there. Work with the individual in their context, strengthening their network. Restraint is absent, as Julie has said. The power of interaction and conversation. Stay close to the person and you will understand. Have a flexible approach. If something isn't working, if a relationship between the operator and the individual isn't working, then change it and allow the journey of recovery to continue. Next slide. Okay. The social model, as we've said, it's about maintaining those social roles and networks, social cooperatives, the family centre. It's all structured around the individual, primarily working with them in their environment. The social habitat, again, as Julie said in the previous, with the ward environment, they're all welcoming. There's no things locked behind cupboards or whatever. It's an open environment, open and welcoming. Okay. Crisis management. It's not a problem. The engagement is a given, as you will be seen 24 hours a day. Again, we are talking about acceptance versus admission. If you require a stay within the service, then you will receive hospitality as opposed to hospitalisation. If the doors are not locked, then not only are you free to leave at any time, but more importantly, you're free to come back. Okay. Our challenge. Well, I think from the pictures we've seen, our environments of care. The challenge will be engaging staff at all levels to work differently, to provide a different kind of service, to wrap our services around the individuals. We are subject to audit and inspections, and I guess if the auditors came and looked at a bathroom that would be similar to the one in Trieste, we'd be asked to close it down and not use it. We've got lots of statutory requirements, and they're going to be a challenge as well, because this is a very different way of working. We need to turn the tide on risk management. It should be positive risk-taking. We've got high sickness rates and absenteeism. Is that because of the way we deliver our services? Is it difficult for staff to work within those environments? Are we asking staff to do things that are fundamentally challenging for them, restraining individuals, medicating people against their will? There's a whole culture change that needs to take place. Our goals. Our goals are to be accessible by all 24 hours a day. We don't want waiting lists. We want people to have choice. We want to move away from hospital admission and treatment to hospitality and time out. And we want to provide day time out. Yep. So, this question, what would you do if I told you that I want to die? Before I went to Trieste? Yeah, I think my answer to that question is very different in light of the visit to Trieste. If we had somebody on a ward who said, I want to die, we'd probably utilise the Mental Health Act, we'd probably put them on one-to-one observations. If you were in Trieste, you'd be listened to, you'd be with somebody would understand and would stay with you throughout that difficult time.
Okay, this is our last slide. It's a very whistle-stop tour through some of our thinking. We all made copious notes and are planning to share those as widely as we can. But this was, again, another quote from one of the young men in one of the projects we went to see, and I think it summed it up for me very much. Very profound when he said it. It was very emotional, but he was very clear that when we described our services back to him, he was again laughing at us. We had a lot of that out there. Whereas his view of that was traditional approaches to mental health in the UK take too long to bring the person back to enjoying life. And he said that was his fundamental goal, was to enjoy life, was to have value in life. And we sometimes get caught up in treating people, trying to make them feel better through treatment, when actually other things could be far more productive. What we haven't focused on in our presentation is a very impressive part of their service out there around social cooperatives. A couple of pictures of them in there give us a lot of food for thought. There's good opportunities locally for people to get involved in lots of great work, lots of great projects, lots of great support systems, and there's opportunities to build on that, because what we saw out there then was that leading to very meaningful employment with a fair wage in the way we'd expect. So it's a big focus for us as well to think of with our third sector, and we've seen a lot of their presentations this week. Just wanted to ask, did anyone answer and stand up yes to all three questions? If so, would you stand up again, please? Okay. That's brilliant. You know, we weren't sure how many that would be, but this is the challenge we've got. For those of you who remain sitting, that isn't a negative. We know that from what we heard yesterday and what we've already learnt is cultural shift will take time. We've got most of the converted in the room, yet we've still got a proportion of people sat down. So if imagine when we start taking this to our wider communities, to some of our staff, to some of our clients who've received a very traditional pattern of service, we know there are going to be some challenges, but we know that's our mission over the next 6 to 12 months, is to start to think about that vision and work this up. And Liz is just going to finish with how we plan to do that.
Okay, we do have an opportunity, which in itself, as Julie says, will pose a real challenge. The Mental Health and Learning Disabilities Directorate acknowledged the real challenge in sustaining the current service model, and evidently we need to deliver services in a way that meets needs with greater immediacy. The goals that we'd stated previously in terms of how we would like our service to be delivered we're going to establish a programme board, a cross-sector programme board, to co-produce our future service model. A learning set, as we saw the huge impact that they've had yesterday, to inform the service model will be an excellent way forward. These are continuous processes as services have to evolve and respond to individuals' requirements continually. To echo John Jenkins's words yesterday, things can only change over time. Thank you.
Well, I thought as a last slide that's a pretty good one in terms of summing up what we're all about. I also thought that was a really good example about what networking is all about, because there's something about reading in books or in articles and in journals, but there's also something about actually experiencing, seeing, feeling what it's like. And as you say, this is a journey. What I liked about that presentation was it was a very honest reflection on where things are now. And I suppose to state an absolutely obvious truth, you can only start a journey where you are. And that's the truth, isn't it? But we'll be really interested to hear as progress goes on over the coming years in these meetings. The next section this morning, we're moving on more specifically to consider